Hello, class. Very good morning. Mm, I was just outside before in the morning, so that's why I couldn't come at 7. But we can start from 7:30 to 8:30. So I will start with the hypothyroidism first of all. So today we're going to discuss about metabolic and hormonal imbalances in our body. So what they can do and how we can see what could the uh, diagnosis for the same also. So in this part, I will introduce to you hypothyroidism, what are the causes and how can we treat it. So the thyroid gland, which regulates the metabolic functions of the body, in virtually every cell, everything from the brain to skin is affected by the hormone and made by the thyroid gland. So hypothyroidism basically slows you down. It makes you lethargic and fatigue, and your hair becomes brittle, and your skin becomes dry, and you become cold much easier than average person. So in this condition, where there is a reduced production of thyroid hormone, so it's categorized as a primary and secondary on the basis of its cause. So primary hypothyroidism occurs due to the improper functioning of the thyroid gland, may be further classified as overt and subclinical hypothyroidism, which affects approximately 5% of individual, with elderly women being most commonly affected. So it's in the women mostly it's happening, and yeah, and also in the kids sometimes, as in newly born kids. And there's a secondary hypothyroidism which occurs due to the inadequate stimulation of thyroid gland by thyroid stimulating hormone. There's a TSH. So there are three hormones in our body: T3, T4, and TSH. Primary is dealing with the T3 and T4, whereas the secondary is dealing with the TSH, your thyroid stimulating hormone. Here we in the right hand figure, we can see the thyroid gland of that human body. So maybe due to the congentional or acquired defects in the pituitary or hypothalamus. Also in our pituitary gland in our brain or hypothalamus, there could be some congentional changes that could lead to this. And this is quite rare and occurs in less than 1% of individual. So hypothyroidism is not so common, but still hyperthyroidism is quite common. In hyper, you have a lot of thyroid hormone production, and which leads you a bit fatty and yeah, extra mass on your body. So some etiology of primary hypothyroidism. So how the thyroid dysfunctions work in this. So autoimmune thyroiditis is one of the things that is possible. This Hashimoto thyroiditis is called as. Then congenital absence or defect in the thyroid tissue, and thyroid removal by surgery, and radioablation by radioactive iodine or irradiation. So destruction of thyroid tissues caused by infiltrative disorders like amyloidosis, sarcoidosis. Then there's impaired synthesis of thyroid hormone, that is iodine deficiency. Most common cause is congenital enzymatic defects. Then there's drug mediated thyroid deficiency by thiamides, amidorines, lithium, aminoglutathamide, carbimazole. So all these medicines could also lead to the uh, impaired function of our thyroid hormone. Then that was about primary hypothyroidism. Now let's talk about secondary hypothyroidism, which is deal with your TSH hormone, thyroid stimulating hormone, or thyroid releasing hormone. So in this, reduced secretion of TSH happen. That is why it's hypothalamic disorder. So tumor is possible. Infiltrative disorders like sarcoidosis, histiocytosis are possible. Then hypopituitarism. In this, mass lesions, pituitary surgery, pituitary irradiations, lymphocytic and hypophysitis is possible. So some symptoms. What are the symptoms of this hypothyroidism? That is, it's tiredness, weight gain with poor appetite, dry skin, cold sensation, hair loss, growth is retarded, constipation, dyspnea, menorrhagia, paresthesia. So all these things are correlated with your hypothyroidism. So all these things could happen to you. So this is very common nowadays, as we can see. Uh, Earlier, it was not so common to see this, disease related to thyroid in a body. But as the like environment is changing, stress level is changing. So we can see a lot of hormone imbalances in our body, our day to day life. There's external physical changes in our body, and there's also internal changes in our body, which cannot be seen on the out front. So at least after like 4 or 5 months, we should have our all our test, our blood test, biochemical test, LFT, thyroid test, complete body test should be done in order to know that if our body is functioning fine or not. So the main reason of today's lecture is to get you in touch with the laboratory diagnostic tests. So that whenever we go to doctor, the doctor says, okay, I can see these symptoms. Go and check your blood test. Go and check your thyroid test. In that, let me know how was your liver function test. Let me know your KFT, kidney function test. Let me know your about all the vitamins and minerals quantity, how much they are present. Yeah. So we never know whenever the vitamin D is less in our body, calcium is less in our body, or any other essential things that are required. So it's always good to make a you know regularly checks for after 4 months or 5 months of complete body checkup, whether the all hormonal things are in balance in our body or not. Then clinical manifestations, the signs are it could be hypertension, uh, skin could be very dry, coarse, puffiness of face, edema, hair loss, and brittle nails, hypertension, slow relaxation of tendon flex, and cavity fusions, normal and large, atrophied thyroid gland, and so on. So hypothyroidism in children, so in delayed growth in children, and delayed appearance of permanent teeth, and delayed or precocious puberty, and pseudo hypertrophy of muscles also. So in children also, if it is happening, so following characteristics are possible in them. So laboratory diagnosis, how we check them in the laboratory, it's a TSH assay, thyroid stimulating assay, in the primary test to establish the diagnosis. So if it is overt, there are two types of hypothyroidism. That is, just a second. So two types of hypothyroidism is overt hypothyroidism and subclinical. So in the overt one, what is happening is you are having T3 and T4 to be less and TSH higher. In the subclinical, T3, T4 remain as it is and TSH is increased. So estimation of free T3 and T4. So test for thyroid autoantibodies, thyroid scan, ultrasonography, or serum cholesterol level, which is increased in the hypothyroidism. So all these things, all these tests are possible, and you can get the results. So in the results also, whenever the diagnostic results came, you will see that in the results sheet there is one normal range, and there will be the results that you got. If from the normal range, if it is increasing or it is lower, that means there's some problem. So try to read your own diagnostic results that's coming from the lab, so you can predict what is the problem is within our body. You can become a doctor by yourself itself. So treatments to mimic normal and physiological level and elevate sign symptoms, biochemical abnormalities. Treatment should be tailored to individual needs. So treatment of choice is levothyroxine LT4 replacement therapy and desiccated thyroid hormone and T3 and T4 mixture. And insufficient evidence and not recommended for replacement therapy by AAC guidelines. So some values also, these functions test has to be checked during the pregnancy, because during the pregnancy our thyroid stimulating hormone is tend to fluctuate a lot. Your T3, T4, TSH, they tend to fluctuate a lot, especially during the trimester. So it's need to be maintained and take regular medicines in order to maintain it. So on this side we can see thyroid hormone T3, T4 and TSH. So this is the normal values initially in non-pregnant women, 3.7 to 7.2 picomole per liter, 12 to 23, 0.27 to 4.2. So in the trimesters, if the lady is pregnant, so in the three trimesters, in the first and the second and third, the value should be belong to this one. If it is not belonging to this one, then extra medicines are given out from outside. So in the kids, congenital hypothyroidism, in the infants, it could be of hypothermia, poor feeding, bradycardia, jaundice, and large posterior fontanel umbilical hernia, which leads to growth failure, markedly delayed bone maturations, delayed eruption of permanent teeth, muscle pseudohypertrophy. So there's so many things could happen to the childrens also because of this particular clinical condition. And this is hypothyroidism is actually related to many other diseases also, like depression, hyperlipidemia, autoimmune disorders, infertility. So it's not just uh, like related to only thyroid stimulating hormone T3 and T4, but also other things it's making it. So students, you will understand the hypothyroidism, you have understood the cause of hypothyroidism, and you will know various approaches to treat it. So that's it. So let's talk about jaundice. So, in this part, we will get to know about the jaundice towards the human body, that how it is happening. Know the various classifications of jaundice, three main classification, right? And then study various approaches to treat it. How can we treat this thing? So, actually, this term as a jaundice, it came from the French word jaune, which means yellow, and it's a yellowish discoloration of tissues resulting from the deposition of bilirubin in your body. So tissue depositions of bilirubin occurs only in the presence of serum hyperbilirubinemia, which is a sign of either liver disease or hemolytic disease. Yeah. So carotenemia and the use of drug quinacrine are few other causes of yellow coloration of tissue also. So carotenemia can be distinguished from jaundice by the sparing of sclera, and in 4 to 37% patients treated with the quinacrine or yellowish discoloration of skin is seen. So unlike carotenemia, quinacrine can cause discoloration of sclera also. So under study normal conditions like 3.9 milligram per kg or 250 to 350 milligram of bilirubin is produced in each day from breakdown of heme from RBCs in spleen and liver. So 1 gram of hemoglobin yields 36.2 milligram of your bilirubin. So let's see how the mechanism of your bilirubin works. So here we can see there's a red blood cells within the macrophage where the death and phagocytosis is taking place. So if in the next step, heme is produced from these RBCs, which could go further into with the help of globulin to make amino acids, and they could be reused for the protein synthesis. Otherwise, it will produce heme, which could produce ferric Fe3 plus, that is your transferrin, and afterwards it produces ferritin, and this ferritin is further is producing your Fe3 plus, that is transferrin, and then making your bone marrow with Fe3 plus globin, vitamin B12 and erythropoietin. So erythropoiesis in red bone marrow is produced here, which could go into the red blood cells and could form again this circulation for about 120 days. So this cycle continues. Then heme could produce biliverdin with the bilirubin. Biliverdin will produce bilirubin, and this could go into the liver, and then from there it goes to small intestine, and further the urobilinogen is produced, which could go into the kidney to produce urobilin, and the urine is then removed out of our kidney. Also from the feces, then urobilinogen could go into the stercobilin, and then in the large intestine it goes via outside body feces. So that's how all your bilirubin mechanism within the body is working out, is playing role. Then there's a Vandenberg test. It's helpful in determining the type of bilirubin present in serum. So normal serum giving a negative Vandenberg test, and it is performed using the diazo reagent. So when diazo reagent is added to serum containing conjugated bilirubin, a purple coloration is obtained within 30 seconds. And this is called drug positive Vandenberg reaction. Some etiological classifications of jaundice, its various types. First is your hemolytic, which is an intracorpuscular defects, and then it's actually hereditary and spherocytosis, and hemoglobin neuropathy, sickle cell anemia, beta thalassemia. And then there's the extracorpuscular defects, which includes infection, malaria, drugs like quinine, sulfonamides, burns, poisons, mismatched blood transfusion. So all these things are possible. And second is your hepatocellular, that is your hepatic jaundice. In this infection is by viral hepatitis, malaria, typhoid, septicemia, and by toxic reagents also, anesthetic agents like halothane, chloroform, your anti-tubercular drugs, rifamycin, isoniazid, PAS, some strong metals like arsenic, mercury, and gold. And the third thing is cirrhosis via portal or biliary. So all these things for the hepatocellular jaundice. And third one, obstructive jaundice, that is a post-hepatic, which includes stones, structures, parasites, head of pancreas, congenital biliary atresia, and so on. and there's a congenital hyperbilirubinemia, which could be of two types, that is unconjugated and conjugated. So unconjugated include disturbance of bilirubin transport, that is Gilbert syndrome, and disturbance of bilirubin conjugation leads to the Craigle-Najjar syndrome. Just remember these names scientifically. Then comes the conjugated, which is a disturbance in the excretion of the bilirubin, that is a Johnson, and there's a syndrome called Rotor syndrome also. So the differences between your hemolytic, hepatic, and obstructive jaundice, prehepatic, hepatic jaundice, and posthepatic. That is your hemolytic and hepatic and obstructive jaundice. So the mechanism of production, so excessive breakdown of RBCs producing unconjugated bilirubin in the mounts more than the healthy liver can conjugate and excrete. An inability of liver to efficiently conjugate transport bilirubin into the bile due to the liver cell damage. And an obstruction of the bile duct, so conjugated bilirubin can't flow through the biliary tracts freely, resulting in the increased serum and conjugated bilirubin. And the type of serum bilirubin accumulated, so unconjugated hyperbilirubinemia, both unconjugated and conjugated bilirubin is increased in serum, and conjugated hyperbilirubinemia. And to check them is your again Vandenberg test. So first is your indirect positive, second is a biphasic, third is a direct positive reaction. Then they, urine bilirubin, it's absent in the first, it's present in the second, and present in the third. Urine urobilinogen, it's increased in the first, decreased in the second, and markedly absent in the third. Fecal stercobilinogen, in the first case, markedly increased, reduced, absent, and then in the fecal fat level, it's normal, increase, and increase, and peripheral blood flow, it's anemia, normal, and normal. Plasma albumin, that is your globin and 8 is to G ratio. In the first case is normal, within second is albumin is decreased and globulin is increased with the AG ratios decreases. In the third case it's normal. So serum, so we can characterize these things, that's it. Like liver function test, they are normal as liver is healthy. In the second it's not, and third is it's mildly impaired, right? So clinical characteristics like pruritus, tender liver, spleen, gallbladder, urine color, stool color. So we see these different characteristics within these conditions. Also breast milk jaundice. So few babies exclusively breastfeed develop jaundice in the second week of life and may continue in the third month. So it is presumed to be due to the inhibitory substance in the breast milk that interfere with the bilirubin conjugations like pre-ganglionic and free fatty acids. So bilirubin level over the 20 milligram per deciliter may be attained, and temporary interpretation of breast milk feed reduces the serum level of bilirubin. And some pathological jaundice in newly born appears within 24 hours of age. An increase of bilirubin in them, we found them to be less than 5 milligram per deciliter per 24 hours. And the total serum bilirubin value is less than 15 milligram per deciliter. And your direct bilirubin value is less than 2 milligram per deciliter. So hemolytic jaundice in newly born. So this condition results from the incompatibility between maternal and fetal blood groups. So rhesus positive fetus may produce antibodies in the rhesus negative mother, and in the rhesus incompatibility first child often escapes and subsequent child would be affected. Sometimes the child is born with severe hemolytic disease, often referred to as erythroblastosis fetolitis. But when blood is more than 20 milligram per deciliter, the capacity of albumin to find bilirubin is exceeded. So we have learned about jaundice, understand the classification of jaundice, and various approaches to evaluate and treat this one. So that's it about the jaundice. Jaundice I have shared. Now we will discuss the last and not the least of today's session, liver function test. So give me just 5 minutes, students. I will come back. So I see you at 8:05. Just give me 2 or 3 minutes. And then we start with the next session of LFT. Liver function test. I'm just coming back. So let's start with the liver function test. So liver is the largest organ in our body, weighing around 1.5 kg, also called kitchen of the body, where the carbohydrate metabolism takes place. So in fat state glycogen synthesis, excess glucose is converted to fatty acids, and then tags which get incorporated to the VLDL and transported to the adipose tissues. So in fasting state, glucose concentration is maintained by glycogenolysis and glyconeogenesis. So protein metabolism, like synthesis of albumin and various plasma proteins, except immunoglobulin, and most of the coagulation factors like fibrinogen, prothrombin, such as 2, 5, 7, 9, 10, 11, 12, 13. So LFT, it has total bilirubin, that is 0.2 to 0.8 milligram per deciliter. Then conjugated bilirubin, which value is 0 to 0.2 milligram per deciliter, and total protein is 6 to 8 gram per deciliter, and albumin 3.5 to 5 gram per deciliter. And coagulation factors includes your 1 to 12 seconds. So the enzymes that are playing in this liver disease, the markers that are playing important role here are ALT, that is your SGPT, then AST, SGOT, then alkaline phosphatase, ALP, gamma glutamyl transferase, GGT, and nucleotidase also. So some special tests other than that, we could go for bile acid level, blood ammonia, alpha 1 antitrypsin, alpha 1 phytoprotein, hepatitis markers, immunoglobulins, ceruloplasmin, and ferritin. So all these tests could also be possible. So total serum bilirubin value should be around 0.2 to 0.8 milligram per deciliter, and for the conjugated bilirubin less than 0.2, and the unconjugated bilirubin 0.2 to 0.6. So this also, in this test also we do this Van der Berg reaction, where the normal serum gives a negative Van der Berg reaction. So basically in this principle is based on the, as the reagent is a mixture of equal volumes of sulfonalic acids in dilute HCl and sodium nitrite. Then that diazotized sulfonalic acid, the above mixture, reacts with the bilirubin to form a purple color known as azobilirubin. So direct positive color, conjugated bilirubin gives a purple color immediately on addition of the reagent, whereas the purple color develops only when the reagents and methanol are added. So unconjugated bilirubin gives colors only when methanol is added into that, not in the other case. And there's a biphasic. In the biphasic, purple color develops an addition of reagent, and addition of methanol intensifies the color, and elevation of both unconjugated and conjugated bilirubin. Then there's indirect positive and direct positive, biphasic, hemolytic jaundice, obstructive jaundice, and hepatic jaundice. So bilirubin in urine, so normally bilirubin is absent in urine, and conjugated bilirubin, being water soluble, is excreted in the urine in the obstructive jaundice. So this can be detected by the Faucher test. So urine bilirubin normally trace amount is present. So in obstructive jaundice, no urobilinogen is present in the urine. So as bilirubin cannot enter the intestine, so the presence of bilirubin in urine and absence of urobilinogen in urine is seen in the obstructive jaundice, that we have just discussed. So in hemolytic jaundice, increased production of bilirubin causes an increased formation of urobilinogen, which appears in the urine. So increased urobilinogen in urine and absence of bilirubin in urine is seen in the hemolytic jaundice. So that's why we see a difference between your obstructive and hemolytic jaundice. And this fecal urobilinogen, which is normal value is about 300 milligram. So this could also be increased in the hemolytic jaundice, in which color feces is the dark. And the obstructive jaundice, urobilinogen is not excreted through feces, and color feces is pale in that case. Serum albumin, how much is present during this condition? So about 10 to 12 gram of albumin is synthesized in liver daily. So its estimation is very valuable in assessing the chronic liver disease, and low serum albumin level is commonly observed in the severe liver diseases. So prothrombin time, that is, goes from normally 11 to 12 seconds. So PT is prolonged in severe parenchymal liver disease due to decreased synthesis of prothrombin. So vitamin K is required for the synthesis of prothrombin, and vitamin K deficiency for synthesis of prothrombin. So vitamin K deficiency can also be lead to prolonged PT. So if PT returns to normal after the vitamin K injection, it indicates that hepatocyte function is good. So some plasma protein of diagnostic values in liver diseases. So albumin, which gives a chronic liver disease and it's change in the concentration, gamma globulins, alpha antitrypsin, ceruloplasmin, alpha fetoprotein, transferrin, and so on. So they provide the following conditions. Then there's a transaminase, that is your ALT. SGPT value is around 3 to 15 international unit per liter, and SGOT value is 4 to 17. So ALT is basically primarily localized to liver. It is a marker enzyme of the liver, and it's present in the cytosol of the hepatocytes of the liver cells. And on the other hand, AST is present in the wide variety of tissues like heart, liver, skeletal muscle, kidney, and brain, and it's both present in the cytosol and mitochondria of the hepatocyte cells. So liver tend to contain both enzymes but more of the ALT. So estimation, if we find out, is very useful in assessing the severity and prognosis of the liver parenchymal diseases, especially infective hepatitis. And they are also very helpful as a screening test in the outbreak of infective hepatitis. So what happens when there is elevated ALT and AST? If it is 20 times higher than the normal values, then it's a viral hepatitis, and this could be drug or toxin induced hepatic necrosis. If its value is normally elevated, that is 3 to 20 times, that's known as a chronic hepatitis because of alcoholic hepatitis, autoimmune hepatitis, acute biliary tract obstruction is taken place in that. And there's this ALP value, if it is from 3 to 13 KAU per deciliter. So the family of zinc metalloenzymes, when is serine at the active center, they release inorganic phosphate from the various organic phosphates. So it's a liver found in the liver in the microvilli of bile caniculi, and so the sinusoidal surface of the hepatocytes. So bone is also another source of this ALP, alkaline phosphatase, and they are highly elevated in the obstructive jaundice and bone disease like rickets also. Then gamma glutamyl transferase, which normal value is around 10 to 15 unit per liter, and it's a membrane-bound glycoprotein which catalyzes the transfer of your gamma glutamyl group to the other peptides and AAS, and they are very useful in the diagnosis of obstructive jaundice. And it is a microsomal enzyme. Serum GGT is highly elevated in obstructive jaundice and alcoholic liver diseases, and this enzyme is an inducible enzyme. Then comes your 5' nucleodase, that is normal to 2 to 15 unit per liter. In this, elevated obstructive jaundice takes place. An advantage of this enzyme is that it is not elevated in bone diseases. So test for assessing detoxification functions of liver, that is your hypopuric acid test. So in this we do is produced in the liver this hypopuric acid when the benzoic combine with the glycine. So what we do is, in order to test this, 6 gram of sodium benzoate is given to the patient, and then urine is collected after the 4 hours. Then hypopuric acid is excreted in urine is estimated. If it is 6 gram of sodium benzoate forms 7.5 gram of hypopuric acid. Then 60% of sodium benzoate, that is your 4.5 gram of hypopuric acid, is excreted in normal. If it is decreased acid excretion is happening, that is less than 3 gram, this will increase the hepatic damage. There is a damage in the cells of your liver cells then. So bilirubin in the normal or mild cases, total protein will be normal, albumin may decrease, globulin will increase, ALP is highly elevated. So BSP retention at 45 minutes could increase in that case. In the alcoholic hepatitis, bilirubin mild elevation is possible, ALP is elevated, ALT is mildly elevated, and GGTs are highly elevated. So you can see all these conditions if somebody got this jaundice test, you can tell by telling these values that this person might be having these conditions. So this is a summary of all the things that we have discussed. Acute hepatitis, chronic hepatitis, cirrhosis, cholestasis, and malignancy. So in all these conditions, your bilirubin, aminotransferase, alkaline phosphatase, albumin, gamma globulins, prothrombin time. So all these values, how much they will be present, how much it will be. Normal to very high, normal to very low, normal to very low, um, and so on. Some are very, very high. So that's it. Something to in touch with medicinal, metabolic, and uh, hormonal imbalances, students. So that was the thing that we want to do it today. Go through them, go through these lectures. If you have any problem, please let me know. I will be happy to answer them. And yeah, so let's see tomorrow. We have done actually very advanced actually versions of everything. This biochemistry. So disturbance in thyroid function, LFT, and jaundice. This has been covered. We have to do the metabolism now of various in our body. So we will deal with that now. Or some carbohydrates and yeah. Okay then. Take care, students. Bye bye. Wish you a nice day. Thank you very much. That's it for today. Dankeschön.